It's 2 minutes past on my clock, so I suggest we get cracking. So good afternoon, everyone, and thank you very much for sparing the time to join us for this webinar on this glorious sunny day. We've run a series of webinars over the last 12 months focusing on the newer weight loss medications, which is very much a hot topic at the moment. On the last two occasions, we've very specifically focused on the medical elements. We've looked at some of the evidence for these treatments, and we've considered some of the prescribing implications around these new medicines. Today, we're very deliberately going to take a different approach. We're going to take a more holistic view of these medications, and we're going to consider the essential role of the wider MDT alongside the medical and prescribing elements. So firstly, a few introductions. So I'm Neil Gupta. I'm medical director at Oviva. I'm a GP in London by background with an interest in type 2 diabetes and obesity. And alongside working for Oviva and being a GP, I've spent many years working in NHS commissioning and was previously the chair of a CCG in North London. And as ever with these sessions, I've got the easy job today. So I'm joined by three fantastic colleagues from our Tier 3 service, Juliet, Jordan and Shane. And once again, they'll be doing all the hard work, and I will let them introduce themselves when we come to their sections. Just a couple of points to note. We're going to aim to finish around 12:50. Ideally, we will have a bit of time for questions at the end. So I believe the Q&A function is up and running. So if you do have some questions, please pop them in the Q&A, and we'll try to take at least a few questions towards the end of the meeting. And just a reminder that the session is being recorded. Okay, and if we move on to the next slide, please. So just to start, just a quick word about Oviva, because I'm sure there may be some people on the call who are not familiar with Oviva. We provide services for people living with weight-related conditions. So that's primarily type 2 diabetes and obesity. And that includes being part of the National NHS Diabetes Prevention Programme, being part of the Diabetes Remission Programme, and specifically relevant to today, it includes the provision of Tier 3 weight management services in both England and Scotland. What makes us slightly different is that we deliver the bulk of our care remotely. So we do that through telephone or video appointments or through the Oviva app, rather than through in-person traditional face-to-face appointments. And what's really important to stress, though, is that we only deliver services within the NHS. We don't have any private self-pay weight management services. And this slide just gives you a bit of background to our coverage and our history, but I'm just going to focus specifically on our Tier 3 weight management service. So we've been delivering Tier 3 weight management services in the NHS since late 2017. And in that time since then, we've received well over 20,000 referrals to our Tier 3 weight management service. And approximately 3 years, I would say now, approximately 3 years ago, we embedded the use of GLP-1 based medication into our Tier 3 pathways. Okay, and so here we have our just a slide showing you our fantastic clinical leadership team for our Tier 3 weight management service, led by our lead consultant endocrinologist, Dr. Wasim Majid. And really just to highlight that the aim of the session is to hear from, given that experience that I've described, is to hear from three of our experienced Tier 3 clinicians who are going to share their knowledge about the medical, dietetic and psychological considerations associated with these medicines. And equally importantly, they're going to share their experience of using these medicines in the real world. I often highlight that many, if not all of us as GPs, will have received little or no training in the management of obesity, yet we are very regularly now seeing patients coming to us asking us for these treatments or asking about these treatments, and we have many patients who are already receiving these treatments either through the NHS or more likely through the private sector. So as ever, the aim of the session is that you come away from the session feeling better equipped to have those conversations with patients, even if you're not necessarily doing the prescribing yourself. And on to the next slide, please. Okay, I'm just going to start with a bit of background, and I won't spend very long on this because I'm sure this is very familiar to most, if not all, on the call. But I do think it is important to set the scene and outline why it's important to treat obesity. So this slide just captures the health consequences of obesity, but also the financial consequences. And if we start on the left-hand side and think about the health consequences, at the top, there's the very well-known and recognized connection with type 2 diabetes. Perhaps less well appreciated is that obesity is a significant risk factor for many of the common cancers, and that includes breast cancer and bowel cancer, and is really second only to smoking in terms of cancer risk factors. But obesity is linked with a whole host of complications and conditions, and some people estimate that's up to 200 different conditions. Many of those are very familiar to us through the metabolic complications of obesity, things like the diabetes, fatty liver disease, heart attack, stroke. But obesity has significant mechanical complications and can lead to conditions like obstructive sleep apnea, osteoarthritis, gastroesophageal reflux. And again, thirdly, and perhaps again less well appreciated, is that obesity has very significant psychological complications. And there's a very strong bidirectional relationship between obesity and common mental health conditions like depression and anxiety. If we then switch and we look at the right-hand side of the slide, not surprisingly, given the impact on the individual, there's a very significant impact on the system. And these figures are taken from a piece of work, a relatively recent piece of work from the Tony Blair Institute and Frontier Economics, which estimated that overweight and obesity together cost the NHS nearly £20 billion per year. And then if you consider the wider cost of obesity, so the wider societal costs of obesity, that includes things like impact on employment, they estimate that the cost is closer to £100 billion per year, or 4% of GDP. And I think we've known a lot of that for a very long time, to be honest with you. I think from my perspective, though, what there's been is there's often been a sense of pessimism around obesity, and there's been a perception that until recently we haven't had any effective treatments barring bariatric surgery. And being honest, there's also been very prevalent attitudes that obesity is it's somehow a choice or a personal failing. It's down to laziness, greediness, or both, rather than being a complex chronic medical condition. But what we've seen over the last few years is the advent of these very effective medications. And I think they've done, from my perspective, I think they've done two things. The first is that they've offered hope to a lot of people living with obesity, whereas previously there was little or none. And in my opinion, I think they are helping, the effectiveness of these drugs is helping to underpin the biological and hormonal basis for obesity, and is helping to tackle some of those attitudes and those stereotypes. Although, to be completely honest, we've clearly got a long way to go. And in terms of these medications, the story really starts with Saxenda, which is liraglutide, which was approved by NICE for use for weight loss in 2020. Once daily injection with fairly average, I would say, weight loss outcomes. The real game changer came with Wegovy, and liraglutide Saxenda is largely obsolete now. The game changer came with Wegovy, which was approved by NICE in 2023, shortly followed by Mounjaro, which is tirzepatide, in 2024. And the point I want to make on this slide is that those three agents, the ones that are in use at the moment, are really only the tip of the iceberg. There are many more GLP-1 based therapies coming, including triple agents, which are potentially even more effective, such as retatrutide, and oral agents like orforglipron. So the point is, these GLP-1 based therapies are not going anywhere anytime soon. They are going to be a core part of our armory for many years to come. And I think, therefore, it's important that we all get familiar with how to use them. And I mentioned that Wegovy and then Mounjaro were game changers. And what do I mean by that? Well, firstly, because they were once weekly injections, and secondly, because they're highly effective in terms of the weight loss achieved. And don't expect you to be able to see everything on this slide, but really just to pull out Wegovy as an example, in the key Wegovy clinical trials, the average weight loss for patients on Wegovy was 15%. And what does that mean? Well, generally, as Shane will outline in a bit more detail, generally, for people living with severe obesity, generally, the greater the amount of weight loss as a percentage, the greater the beneficial impact on health. And 15% weight loss can have a life-changing impact on many obesity-related complications. So that's the good news. So we have highly effective treatments, and we've got even more effective treatments potentially coming soon. The bad news, so to speak, is that when we look at the service landscape through which to deliver those treatments, we can see, and I think all of us know this, that it is not fit for purpose. So access to tier 3 weight management services, so those multidisciplinary specialist weight management services, we know is generally very poor and it's highly variable. It's the classic postcode lottery. And if we look at that just purely through the lens of eligibility for Wegovy, in 2023, when NICE approved Wegovy, they estimated that 4 million people were eligible to receive the drug. But at the same time, NHS England estimated that there were only 35,000 places in tier 3 weight management services across the whole country. So you've got 4 million versus 35,000, and clearly there is a very significant mismatch between the need in the system and the actual capacity within that system. And why is that important? Why is that shortfall in access to specialist NHS specialist weight management services important? What are the implications of that? Well, firstly, and I think everyone on this call is probably seeing this, is that that is resulting in very high numbers of patients turning to the private sector to access these treatments, and that is actively driving health inequalities. So those patients who stand to benefit most from these treatments are not necessarily the ones who are accessing them. For those who are able to access those treatments through the private sector, often they're not receiving the right level of clinical support that they need, and that's generating additional clinical risk. And as we know, it's generating additional workload for general practice. And what that means, not having the right level of support alongside the prescription of the medication, is that you see very high discontinuation rates of these GLP-1 therapies. And that is a really bad outcome. So that sudden unplanned cessation of these medications is a really bad outcome for the patient and for the system, because as we know, they almost inevitably will regain the weight that they've lost. And in many instances, they may end up metabolically more unhealthy than when they first started. And we don't have data from the UK private sector in terms of discontinuation rates, because that data isn't published by those self-pay private providers and may not even be being collected. So we have to turn to what evidence is out there, which largely comes from the States. And what that shows is that, firstly, discontinuation rates of GLP-1 medication are very high. The discontinuation rates are higher when the medicine is being used for obesity rather than type 2 diabetes. And the study suggests that at 12 months, approximately 35% of people are still using the medication. So only 35% still using them around the 12-month mark. And what are the reasons for that? Well, for me, the main reason is because people are not getting the holistic support alongside the prescription of the medication. And the reason that that's required is because this is a complex population. So, and I mean that in terms of medically, psychologically, and socially. They have a heavy burden of comorbidities, and that's in terms of physical health conditions and mental health conditions. And we know, and I'm sure everyone on this call knows, that side effects with these medications are very common. And often patients require a lot of support to help manage and tolerate those side effects, especially early on in the titration phases. One thing to consider as well is that weight loss will almost inevitably plateau. Okay, and once the weight stops dropping at that rate or starts to plateau, inevitably it becomes harder to maintain motivation and engagement, and that's where that support is really essential. And finally, and obviously, where cost is a factor, that will inevitably be driving higher discontinuation rates. So we don't have that figure for the UK private sector, but I suspect that if we did, it would be much lower still than the 35% that we see in some of the literature. What I would say is what we're trying to do by offering a holistic multidisciplinary specialist weight management service through the NHS is to try to tackle some of those challenges, to help people stay on the medication, to ultimately to help people achieve optimal outcomes. And with that, I'm going to hand you over to Shay.
Thanks, Neil. So I'm Shay Mehta. I'm medical lead with Oviva. I'm also a practicing London-based GP and have experience providing clinical leadership for weight management and diabetes services for an ICB. In the next 10 minutes, I'm going to take you through a high-level overview of how we deliver medical obesity care within our Tier 3 weight management service. And I'll give you some nuggets of information, some practical guides as to how we do that to achieve the best outcomes for our patients. So when we think about obesity, you'll all be familiar with the definition here on the left. A BMI of greater than or equal to 30. But this really doesn't capture the complexity of the disease. And, as my colleague has already alluded to capture the complexity of obesity as a complex, chronic, progressive, relapsing, but treatable disease. But that's multifactorial. And of course, in patients with a clinical obesity, you see metabolic dysfunction and organ damage, and the impact on their health, both the physical, the psychological, but also the social impact this has for them is really stark. And it's through that lens, actually, that we deliver medical obesity care at Oviva. The patients we see have high starting BMIs. In fact, I think the average starting BMI is 47. And with that comes a high degree of comorbidity and complexity that comes with that as well. So in terms of the current obesity medical treatments that we use, the two drugs are Wegovy and Mounjaro. Within our service at present, we are prescribing Wegovy, and we hope to introduce Mounjaro very soon. Both drugs are effective, as you can see here. They're very similar in terms of the criteria for eligibility according to NICE, and they're both once weekly injection pens available in a range of strengths. Neither of these are subject to the shortage criteria, which means that they can be prescribed. They're available for patients within the UK. Slide, please. So on our medication titration pathway, our aim is to keep patients on the medications and achieve good adherence, and also to help patients titrate to the maximum tolerated dose. We know that it's through both of these measures that we achieve the best outcomes, by keeping patients on the medication and helping them titrate to the maximum dose. How do we achieve this? Well, there are 4 key points that I want to raise that we really try to incorporate into delivery of the drugs and through the care that patients receive. The first is a real focus on shared decision making. The appointments with their prescribing clinician, be it their medical doctor or obesity nurse specialist, will be used to address patient concerns, queries, and really focus on that approach to make sure that we answer questions and support patients to address those concerns as early as possible. Where patients are more anxious about being on the medication or have concerns about injections, they're offered a tailored approach with perhaps a slower titration schedule, for example. So not all patients titrate to the maximum dose at the same rate. Throughout the patient journey with us, we have the full complement of multidisciplinary team support, both from the dietetics team, the clinical psychologists within our team, as well as our lead medical consultant. Every week, we have a weekly consultant-led MDT, and patients who are struggling with various aspects of their journey with us can be referred into an integrated weekly MDT, where all members of that multidisciplinary team can work together to ensure that we have a tailored, personalized plan for that patient and a shared approach to helping them achieve their key weight loss goals. The third thing to flag is that patients can receive bespoke coaching via our app, and that's a key highlight of the patient journey with us. The last thing to note is that patients will, invariably at some points in their titration journey, experience a degree of side effects. And actually, we take a really proactive approach to managing these. Patients in hours have access to our obesity specialist clinicians to support with side effect management. And that's a key part of our offer that I think helps patients manage those side effects proactively and stay on the medication to achieve the best outcomes they can. When it comes to side effects, the most common side effects that are experienced are listed on this slide. So you'll see that the most common ones that are experienced are the GI side effects, as you might expect, nausea, vomiting, diarrhea, constipation, perhaps mild abdominal pain. Some patients also report experiencing headaches. Now, while side effects can be frequent, not all patients will experience all of these, and some, to be honest, experience none at all, and will have a very smooth titration journey. But we find that patients are most likely to experience side effects once they titrate to a higher dose. So at every dose escalation point, they might notice a slight flare in some symptoms, and these are some of the common side effects they might experience. But as the weeks go on a particular dose, we find in most cases side effects dissipate, and it's about supporting patients through that journey. So we do that proactively by embedding education about side effect management and the simple measures that patients can take to avoid these, both within our Learn content that patients have access to, and also in webinars that all patients are also receive to help manage these side effects. You'll see listed here, simple tips often make a big difference. So eating smaller meals, taking sips of cool water or cool drink can really help. And lifestyle measures such as not lying down straight after eating can have a big impact. I've mentioned already that patients have access to in hours to our side effect management support via an obesity specialist clinician, and I think that's a key part of our offering. But at all points, that we have to note that sometimes it's rare, but there can be occurrence of more severe side effects. And so if patients have very severe or worsening abdominal pain, they are given clear safety netting advice that they must seek urgent support and assessment. In terms of other points to note, given it's quite topical, there's been recent MHRA guidance on this, but also, so to go back a slide just for a second, there's been recent MHRA guidance on this, is that contraception counselling is really, really important in patients who are on these medications. Of course, the medication is untested in pregnancy, and those who are trying to conceive absolutely should not be starting on GLP-1 medication. And we know that for those on contraception, specific advice is needed, but in terms of at every dose escalation, patients should use alternate forms of contraception to just the oral contraceptive pill. Barrier methods must be used alongside that, and actually strict contraception counselling is a key part of the advice that we give patients within our service. Next slide. Medications support effective weight loss by creating a negative energy balance. And whilst that's really, really key, we know that the management of obesity is much, much more complicated. And the reality is there's an interplay of several factors. And you can see here on this obesity system map that was designed in collaboration with Public Health England, that there is an interplay of several factors. The psychosocial economic factors are really, really important. And it's there that a holistic lens and MDT support is key to enhance patient outcomes. So why do incremental improvements in weight loss matter? What is the impact? And you'll see on this slide here a summary of key studies and trial data. Of course, even weight loss at the 5% level has a clear impact, but it's when we achieve weight loss levels of 15+%, you can see alongside improvements in cholesterol, blood pressure readings, it's at those levels that patients achieve things like diabetes remission, improvements in fatty liver disease, and also improvement in symptoms of sleep apnea, asthma exacerbations, and also a reduction in cardiovascular outcomes. So this is why achieving incremental weight loss really, really does have an impact, and not just on the weight loss outcomes, but on many conditions that we may not always consider at the forefront. So with that, I'll hand you over to my colleague to take you through the section on nutrition and lifestyle support.
Thank you, Shane. My name is Juliet Finney. I'm the clinical lead dietitian for our Tier 3 weight management pathway at Obiva. And what I wanted to speak with you today about is about our nutrition and lifestyle supports that we use as part of this essential holistic support to patients to optimize outcomes, but also to optimize health, not just thinking about numbers on the scale, but how we support all of our patients to achieve healthier lives overall. And it goes beyond just the nutrition, which is why I wanted to focus on lifestyle approaches as well today. We are fortunate to have a very specialist and very experienced team of dietitians and nutritionists within our team who do provide that holistic support to our patients. And what we do is firstly make sure that we do provide evidence-based nutritional advice, and that's always going to be the ground rock of what we do. And that's individualized to every patient. And as Shane and Neil have mentioned already, we have quite a complexity of and quite a variety of different patients who join us in our pathway, often with very difficult journeys until they've reached our point, often with multiple comorbidities, and those could be physical, they can be psychological, they can be a combination thereof of multiple comorbidities. And we will always tailor the nutrition advice around the comorbidities that our patients are living with to make sure it's appropriate for the patients. And that's where it's essential to have specialist nutritionists and dietitians who have that background and who are able to really tailor that advice to the individual. Another key point from a nutritional point of view is making sure that we ensure dietary adequacy. So as we know, these medications work by reducing appetite, by reducing overall food intake, which is a real positive, and that's how they work. But within that, then you have reduced opportunities to achieve all of the nutritional requirements that the body has in terms of particularly protein, but also micronutrients as well. So our teams work closely with patients to make sure that what they are eating is balanced and that they are able to achieve the nutrition that they need. And with that often comes a change in focus. And our patients often find that they're less focused now on restricting and reducing because the medication's helping with that. And they can shift that focus to a much more positive outlook on food and in terms of thinking about what's the goodness that this food can provide, what nutrition can it provide for me, and starting to see food in a more positive light. Our teams are also very skilled in facilitating behaviour change, and I think this is absolutely essential because we're not only looking at during treatment with the medication, when often it's easier to manage challenging situations, such as, for example, managing cravings and emotional eating, but also planning for the future, planning for potential medication cessation in the future, and how we manage those really challenging situations. Because we don't want to only support patients to lose weight during the 2 years of treatment. We want to support patients to maintain that weight loss wherever possible and to minimize that risk of weight regain afterwards. We have really close alignment between our teams within our MDT, and you've already heard from Shane on the medical side of the MDT, and then you'll hear from Jordan shortly on the psychological side. And it's absolutely essential that we all align in how we're supporting our patients, making sure that we've got approaches that work in parallel and we all understand what the patient's goals are, what their plan is, and that we're all supporting them in the same way. So working closely together is absolutely essential to what we do. But then we go beyond the nutrition support for our patients as well, and physical activity I'll talk to you about in a little bit more detail shortly, and making sure that we're supporting goal setting for our patients as part of that behaviour change approach. And other aspects of lifestyle that we'll support is really anything that has a positive impact on health, and that can include sleep, stress management, social support, signposting to other organisations and local support where appropriate as well. And it's really essential, I think, for us to provide that holistic support and not just look at one area, such as nutrition on its own, because that's never going to achieve those overall health benefits that we want to achieve. The next thing that I wanted to speak to you about today is some of the questions that our patients come to us with, particularly when they're starting out on Wegovy treatment, and they're planning their next steps and some of the concerns that they might have as well. Because I suspect that a lot of the questions that they're asking us are potentially questions that they ask yourselves as well. So we'll talk through some of these and also how we answer these questions and how we guide our patients to support them too. So one of the key questions that patients often ask is, should I be restricting, or how many calories should I eat, or can you tell me my calorie target for the day? And this often comes from years and years of restrictive approaches, from calorie counting, from point counting in various ways in the past. But as I mentioned earlier, often we can facilitate this move away from restrictive approaches, so that we can take nutrition beyond just cutting down in numbers and not having too much, to think about all the positives, think about the fiber and the protein and the goodness in food. And often that means that you don't need to count calories, you don't need to restrict, because the medication itself supports that natural reduction in the volume of food eaten as well. So we really we can give people a calorie figure as a guidance if they're keen to have that. You know, absolutely, it's about individualizing what that patient feels is helpful for them. But we also want to facilitate that move away from restrictive approaches to that more positive relationship with food. People may ask, can I use meal replacements? And some people are interested in doing total diet replacement or TDR approaches, and that is something that we discourage most of the time. Again, you know, there are individual exceptions, but we do discourage that most of the time, because what we found is it doesn't add any benefit in terms of weight loss over and above what our patients are achieving through healthy, balanced eating plus the medication. But what it does add is a lot of practical difficulties, and it doesn't provide that planning and problem solving around challenges that people can then take forward into their future eating patterns as well. But where they might use meal replacements effectively is for somebody who's really struggling to establish a regular meal pattern. You know, a lot of people have a really restrictive pattern of eating, which could lead to overeating later. So if somebody's trying to establish a more steady, regular meal pattern, then using occasional meal replacements can be helpful. For example, to fit in a balanced breakfast on a busy day, which is far superior to not having a breakfast at all, for example. Patients often ask us about supplements. Should I take a vitamin supplement? Should I take a protein supplement? We do recommend a balanced A to Z multivitamin supplement for most people who are on Wegovy treatment. The reason being, again, that smaller intake of food, fewer opportunities to get all of the nutrition that you need. And we see that as a backup and an insurance to making sure that they are meeting their micronutrient needs. We will always do that within the context of any particular diagnosed deficiencies or any supplements somebody's already taking, to make sure that we're avoiding that risk of toxicity or having too much as well. And in terms of protein supplements, those are occasionally used, but we really try and encourage protein from food sources wherever possible, so that you can get the other benefits. So for example, if you increase your beans, pulses, chickpeas in your diet, not only are you getting more protein, but you get more fiber, you get the calcium, you get the iron from those sources as well. So you get that much better overall balance. So the food sources are very much our first line encouragement there. People might ask about side effects. How can I reduce all the side effects that Shane has just mentioned? And our nutrition, lifestyle, dietitian support team can really help with the side effect management, particularly first line approaches to managing side effects that can then prevent escalation to the medical team. And that allows then Shane's specialist team to focus on the patients who are struggling with that higher level with side effects. So we can manage the first line side effects such as nausea and constipation through diet and lifestyle approaches quite effectively. And it's all sitting within that MDT approach. And then finally, people may well ask about their other conditions. And as I mentioned before, people often come with multiple comorbidities. They might have type 2 diabetes, they might have CKD, they might have gastro conditions. And how do we tailor the nutrition advice that we're providing around those other conditions? And that's where our real specialist clinicians come in and support our patients really well and bring a lot of experience from working in all of these different areas. And again, it's about not having a one size fits all approach, which never works. Every patient is an individual, and we need to support around the comorbidities that people are experiencing to make sure that we're optimizing their outcomes and their health as well. The final thing that I wanted to speak with you about this morning, before I hand over to Jordan, is about physical activity. And again, this is about going beyond nutrition, and our dietitian nutritionist teams are very well versed and trained in supporting patients to increase their movement and their physical activity. And we see this as an essential part of treatment, and we try and make sure our patients see this as an essential part of treatment as well. But as we mentioned a few times now, our patients are complex. Often they find it very difficult to incorporate physical activity. They have lots of barriers, to be it social, physical, psychological barriers to implementing this. And we're very well practiced in supporting people to build up from a very low level, gradually building their physical activity. And they may not meet the WHO guidelines now, and they may struggle to ever meet them, but we can build on where they are now and make really meaningful increases. And that could include, for example, chair-based exercises. And we like to provide videos and really practical guidance on how to do this to make it really implementable. We focus on reducing sedentary time as well, because even if you can't get in regular physical activity, if you can break up the sedentary time, that can be really impactful on health outcomes too. And strength and resistance training is a really important one. And that looks different from everybody. And we do have some people weight training in the gym, but we also have people doing very lighter exercises based in their chair at home and everything in between as well. The key thing I think is setting realistic goals that are clear to the patient and they know exactly what to do, and providing that practical support, the videos, the ideas, to make it less abstract and more something that they can really take forward. And very similar to what we've said about nutrition so far, we want to change the focus in exercise and activity to be about being the positives, the well-being, the improvements to your health, the feeling stronger, reducing your risk of falls, balancing better, feeling better after going for a walk. Think about all those positives rather than the mindset that people might have been in the past of, well, I need to exercise to lose weight, or I need to go to the gym and burn X number of calories, which we know isn't effective as a weight loss approach, but it can have really meaningful impacts on all other aspects of health, and particularly psychological health as well. So that is a really good point to bring me on to hand over to my colleague, Dr. Jordan Bibby, who will take you from here.
Thanks, Juliet. And yeah, just to explain, I'm Jordan, clinical psychologist and the lead for psychology in the Tier 3 weight management service. So here are just some of the lovely faces of our team. And we're getting more and more diverse, which is really important in terms of the care that we can offer. And I'll explain this later too. So we've got Yakovina, who's one of our senior clinical psychologists. We've got Simon, a psychology support worker. And we've got Fleur, who's a senior psychological wellbeing practitioner. And now the team is growing and growing, and we've got health psychologists too, with lots of experience in kind of eating disorder services, weight management services, physical health, pain management teams. So it's really diverse and a great team to be in. Next slide, please. So psychology in Tier 3, in terms of what we offer here, it's a steps care approach, and this is based on evidence too, clinical expertise and feedback from our patients. So the reason we've got this step care approach is just as Shane, Neil, and Juliet has explained, each patient we see is individual, and there's so many factors that contribute to obesity, and there is that kind of bi-directional relationship too, with mental health difficulties, but also many other factors too. So in terms of the step care approach, what this is, and again, the diversity of our team that can allow for this, we know that the NICE guidelines recommend digital interventions for diet and exercise or behavioral change. So it's under the umbrella term of behavioral modification. So what is that though? So one of the approaches, behavioral modification, that we use at Oviva, it's embedded in our app, it's embedded in our learn content that we use patients to have access to, and it's developed by us too. So clinical psychologists, our dietitians, that have got lots of experience in this. So one of those approaches is self-monitoring, for example, the use of a food diary. and then the live feedback for patients with this. Now, it's really important that this is not a, whilst that's embedded in all parts of our care, we are able to identify the patients that need additional care and their care to be stepped up. And again, going back to that self-monitoring, for example, whilst that's recommended as a behavioral modification technique, we would not recommend that for somebody who has disordered eating or has restrictive, kind of relationship with food, or might struggle with self-esteem, or difficulties with the body image. So this is where the tailored care and the step care is really important. So in this example, if a patient was experiencing these things, our team, let's say they triaged and they see a psychological well-being practitioner, that member of the team can step the care up to a health psychologist or a clinical psychologist. And then we can offer, for example, a cognitive behavioral therapy approach, which we know can be helpful in this regard. So it is, there's various interventions that we can offer based off different team members and training background. So, this the higher degree of variability, just as anecdotally, and it would be backed by the literature too. Our patients could be struggling with, for example, low mood, anxiety. That's one of the highest kind of comorbidities or prevalence rates, and we know that's bidirectional. So you're at 55% to 60% greater likelihood to experience depression if you are obese, and that relationship goes the other way as well. It increases the risk for depression if you are obese. So there's also other presentations. So a lot of our patients have ADHD or other neurodivergence. They may be autistic or may struggle with what we call interoception, recognizing hunger, satiety, emotional experience. All of these things are important and uniquely contribute to that person's relationship with food, their mental health, and what they need within their weight management care. Yeah, there we go. I can just see a bit of a lag. You can see the next slide there. So in terms of the actual pathway, how this works, how we can tailor our interventions and the care that a patient has. From triage, we know that it's not a case of one size fits all. So how do we determine this? We use gold standard kind of measures to determine this. So we use the PHQ-9 for depression, low mood risk. We also use the kind of questionnaires on binge eating disorder. This is to do with safety, not just level of care as well. So of course, it's not recommended that patients take part in a weight management program if they are struggling with binge eating disorder. And we can assess for this as well as part of our psychology team and what we offer. And we can then signpost to relevant services. So we do, using these measures, we can determine what level of care from triage a patient requires. But also we do have weekly binge eating disorder and eating disorder meetings, and that's a senior dietitian and Julia included, and myself within the psychology team, where we will review the patients flagged by our team as requiring kind of additional support, and we can decide the right care safely from this point, and if they need to be stepped up with the kind of treatment they receive. So once if an individual is going through this journey with us, they may be offered different kind of treatments, as I've stated. So first one, an individual might not need any psychology support at all. And in which case, again, our dietitians have been trained in terms of behavioral change techniques at the point of entering the team. And this is embedded within the app as well, and the learn content we offer. So we offer guided self-help as well. Now, there's a range of kind of topics we do cover, and they are informed by approaches such as cognitive behavioral therapy, behavioral change techniques, as I mentioned, and also acceptance and commitment therapy too. Now, the next level is app coaching. So this will be live coaching with a member of the psychology team and, of course, a dietitian team and our health coaches. But in terms of psychology, that means a member of the psychology team will see the input that the patient provides through the app, and they can respond to that live, and give them support through the app throughout that program at regular intervals. Following on from this, there will be telephone or video calls with the individual, and that's where these tailored kind of support can be given, and based on the complexity, comorbidities, and their background. And we might cover things like their relationship with food. A lot of our patients and individuals with obesity might have experienced negative experiences with food. Sometimes it can be histories of abuse, such as neglect, or food might have been limited at one point. So that's why it needs this tailored approach. There can be so many factors that contribute to that relationship with food. And as Juliet mentioned before, emotional eating is quite a common topic that we support with. Okay, and so how do we provide this tailored support? How is it made flexible in terms of the context of GLP-1s within the service too? So we know the time with Oviva and starting the care with us, it opens a really crucial window for long-term change, as Juliet mentioned. So it's not just about when they are with us, kind of receiving the medication and the wraparound care within the MDT here, but we want this for long term and to maintain this. So this window of opportunity, it allows this. So we can use these techniques and support that healthy relationship with food, and the change of this mindset, approaching, for example, targets to achieve or goals to achieve rather than restriction, or avoiding certain things, which can be more difficult and not sustainable. So we want to make these things, enjoyable as possible, so this behavior is going to continue. We might look at kind of, taking a CBT approach. We might look at recording instances when emotional eating has occurred, what underlying emotions there were here, what was the environment like, and then we can actually support with changing this. So it's those underlying psychological factors that we want to support with, and we can signpost onto other services, and that's where the psychology assessment is important. We can determine safety there as well, and what we can offer, and where there are limitations to this. It's really important that as Neil mentioned, the adherence rate is quite low for GLP-1s within randomized control trials. And there can be many reasons for this, mental health being one of these. And we know that even monitored exercise, whilst taking GLP-1 receptor agonists, it can lead to long-term change, and a combination of the medication, adhering to the medication and these behavior change techniques will then continue a year after treatment terminating, and that's randomized control trial published in The Lancet, Jensen, 2024. Okay. Okay, so what is the impact that we see in psychological impact of GLP-1 receptor agonists? So, our patients are often experiencing a reduction in food noise that they've, quite often this has impacted their relationship with food, and has contributed to their eating behaviors. And we're finding that a lot of patients then, once they start the medication, they've got room to start the behavioral modification and make those habits, those changes behaviorally for the long term. So there's shifts in appetite, food preferences. Quite often there's reduction in alcohol consumption or smoking, which is really positive. This kind of holistic change in the health and the quality of life, it's really common. And then we can, again, in psychology, we can suggest the healthier coping mechanisms, look at this, record it, reflect on this with the individual, and then start to implement new coping strategies. For example, seeking social support. The risk of binge eating is quite often reduced. And again, this needs to be tailored with a psychology professional, but we are finding that quite often overeating reduces, and turning to food to cope with emotions as well often reduces, and we can implement these again for the long term once the medication is stopped. So, there's some emerging evidence too that there's changes biologically in reward systems in the brain with GLP-1 receptor agonists. So, that could be an underlying factor to this as well. Okay, and that's it for myself. I'll pass back to Neil. But lovely to speak today.
Thank you, Jordan, and thank you to Juliet and Shane as well. That was great. So I'm conscious of time. There's about 8 minutes left, so I'm going to rattle through a couple more slides and see if we get time to take any questions. Apologies if we don't. So first thing I want to do is just remind people about how you can help your patients access multidisciplinary specialist weight management care. I'm pleased to say, and I'm sure many people on the call know this, that Oviva's Tier 3 service is available to all patients in England via GP referral under the right to choose legislation. What does that mean? Well, under the NHS Constitution, patients in England have a legal right to choose which provider delivers their consultant-led specialist care, and that doesn't necessarily need to be the provider that is geographically closest to them. So if with their GP, a patient is deemed eligible for referral to a Tier 3 service, that patient can elect to be referred to Oviva's Tier 3 service rather than a local service if one exists locally. Next slide, please. And why is it important? So why is it important that you do refer your patients onto a multidisciplinary specialist weight management service like Oviva's? I just want to stress this point that this is a very complex population in terms of many characteristics. And I think I've just presented a snapshot here of the characteristics of the patient population that we work with. And the first thing I would highlight, and Shane has already alluded to this, that the average starting BMI for patients in our service is 47. So that is a BMI level that will reduce your life expectancy by over 10 years. And with that level of obesity comes a significant degree of medical, psychological, and social complexity. So the patients that we see have a lot of comorbidities, and that's both in terms of physical health conditions, but also in terms of mental health conditions, including serious mental illness. But I just want to focus for a second as well on the social side. So if we think about deprivation, we see that patients from the most deprived population deciles are overrepresented in our service. We see that of our patients, 13% of our patients report being unemployed. That's about 3 times the national average, and nearly 30% of patients report having a disability. And I think hopefully that just starts to give you a sense of the complexity of the patient population and the complexity that comes with complex obesity. Next slide, please. So, but there is good news, because when we look at the outcomes that we're helping our patients to achieve, we can see that despite the complexity of the population, for our patients on Wegovy at 12 months, the average weight loss that we see in our service is just over 15% weight loss. Okay, and hopefully most of you will recall that 15% figure is broadly identical to the figure that was seen in the key Wegovy trials that I presented earlier. And I think one of the things that we're most proud of is that we are helping our patient group, despite the fact that it is a much more complex population group than the population that was in the Wegovy trials. We're helping them achieve equivalent weight loss. And just to give you a flavour of that, so in the key Wegovy trials, the STEP trials, the average BMI in those trials was around 37, so a whole 10 points lower. Anyone with a serious mental illness was excluded from those trials. In fact, anyone with depression in the preceding 2 years was excluded from those trials. Whereas in our service, we don't exclude anyone on the basis of any specific mental health diagnosis. One of the main exclusions would be an active eating disorder, but we're generally trying to include people in the service. And as I say, we're very proud that we've been able to deliver equivalent outcomes as those seen in the trials, despite a much greater degree of complexity. And the obvious question is, well, how can you do that? That's not the norm. Normally, we see real-world outcomes fall short of clinical trial outcomes because clinical trials are run in artificial conditions with artificial populations. And really the reason we're able to do that is because of the level of holistic multidisciplinary support that we offer alongside the medication prescription. So we are very much, not just focused on prescribing these medications, as hopefully today's session's given you a flavour. It's very much about that holistic multidisciplinary support. Last slide, please. Just a reminder about how you can refer your patients into the Tier 3 service. So it's relatively simple. You need to complete a referral form, which you can find at oviva.com/refer, and then send that in either through NHS Mail or using ERS. Auto-populating versions of the form are available via Ardent in some ICB areas. Okay, I'm going to stop there, and I've left us all of 2 minutes to take questions. So apologies, that is clearly not a very long time. But there's one question that I think jumped out at me in the published group, which is around what happens when people stop the medication. I just think it's such an important consideration. And I think what I would say is clearly this is an area that we're all learning. And I think one of the things that I would stress is we are trying to avoid that sudden cessation, because the evidence suggests, there was some recent evidence from Susan Jebb, who's a professor in Oxford, presented at the European Congress on Obesity, looking at weight regain after cessation of GLP-1 medications. What that group showed was that the history of the research in this area is, even with behavioral weight loss interventions, the tendency tends to be weight regain over time. What they are suggesting in some of that evidence is that the rate of weight regain may be even higher with so people may regain weight quicker with cessation of GLP-1 medications than they would after a behavioral Tier 3 or behavioral weight loss intervention. What we're also, some of the evidence is suggesting that when people lose weight rapidly through the GLP-1 medication, they tend to lose disproportionate amount of muscle, although there's some controversial area and there are different views on that. So they may be losing a lot of muscle, but when they regain the weight, they preferentially regain fat. So their body composition, it may just not be the overall weight alone, it may be that their body composition has also changed and they're metabolically more unhealthy than when they first started, which again is one of the reasons why just prescribing these medications alone to this complex population is just not an option. Tackling some of those things that we've only just scratched the surface about, some of the underlying drivers, relationship with food, relationship with physical activity, etc., to try and give people the best chance of losing weight, but also of keeping that weight off. But it's an area that there is lots and lots of research in terms of what happens, and I don't think anyone could honestly say what is the best approach in the longer term right now. And there's lots of studies looking at that in terms of lower dosing long term or different approaches to helping people come off. I'm really sorry, we are right at time at 1 o'clock. So I'm going to bring us to a close now. And I just want to say a big thank you to everyone again for sparing the time to join us. Okay, take care.
Bye.